Good morning, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode, and you will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and use the I will call in telephone option. But please remember you must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on FADA's website within 30 business days. To access the recording and PowerPoint, go to www.fada.org, then to our Resource Center, and then to our training library. FADA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credits for webinars and workshops taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FADA's website. You will need to register or sign into your account to complete the evaluation. Please remember, you must have your same email address you used today when you register for the website as what you have listed on your FADA website. Information you provide FADA as a part of registration remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes for persons completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close midnight Tuesday, November 29th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers when you register for our webinars. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrivals and departures of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Dr. Jonna Byars is a licensed professional counselor and national certified counselor and has a private practice focused on trauma and addiction. She is a nationally recognized speaker on the topics of addiction, trauma, anxiety, and ambiguous grief. Dr. Byars has also written extensively on the topic of trauma, addiction, and grief. She is the author of the book, Education Under Pressure, Management of Stress and Anxiety in Graduate Studies. Dr. Byars also contributed to the chapter Women and Substance Abuse in a textbook Counseling Women, published by Kendall Hunt, and has written numerous articles on the connection between trauma and substance abuse. Dr. Byers' current research interest includes the mental health effects of untreated trauma, complex post-trauma stress disorder, addiction, and social media. And now I'm going to turn the presentation over to you, Dr. Byers.
Great. Thank you so much. Thank you all for coming. I'm going to be talking to you today about substance abuse from treatment to long-term recovery and some of the things that we find that interfere with the long-term recovery that those who use substances so much need. So some of our learning objectives are, I'm going to describe the role of behavioral health professionals in supporting long-term recovery, the role of the individual in long-term recovery. We're going to identify areas of identity, character, and relationships that lead to long-term recovery. And we're going to understand the role of unprocessed trauma in long-term recovery and discover effective treatment modalities for processing trauma as it relates to long-term recovery from substance abuse. Last, we'll identify the skills necessary to help individuals with long-term recovery focused, and this will include rebuilding of identity, relationships, and social support networks. So here's the outline. I'm going to go over some definitions and statistics. I'm going to talk about our current short-term recovery treatments. I'm going to talk a little bit about long-term adherence rates, short-term treatment methods, and what does long-term recovery mean? What is the role of the counselor, and what is the role of the individual? And last, I'll spend a good chunk of time talking about trauma and its role in long-term recovery, because what we found is that some of the trauma is leading to the dual diagnosis, and without addressing these issues, long-term recovery becomes virtually impossible. So first, a definition of addiction. It's defined as a chronic, relapsing brain disease. It's characterized by compulsive drug seeking and use, despite its harmful consequences. It's considered a brain disease because drugs change the brain. They change the structure and how it works. So despite the negative consequences, people who become addicted continue to seek it out. The brain is altered as a result of the use. Some stats. 40 to 60% of people with substance use disorders relapse after completing treatment. And when I say that, I mean the short-term 1-month treatment. It's this 90-day period after the 1-month or 6-week treatment that's the danger zone. And so essentially 50% of people relapse within that 90-day period after short-term treatment. The drugs, alcohol and opioids, have the highest rates of relapse. Some studies indicate a relapse rate for alcohol as high as 80% during the first year. Some studies show relapse rate for opioids as high as 80 to 95% during the first year. Other substances that have high relapse rates are stimulants and benzodiazepines. So as you can see, relapse is an issue, very long-standing issue. So initially, when clients or people come into treatment, here's the short-term treatment steps that address substance use disorder. They're detox. They get off the substance. They usually have behavioral counseling. They have medication that can help with the detox, and the medication can also help with mood stabilizing. There's often an evaluation and treatment for co-occurring mental disorders such as depression and anxiety, PTSD, and other cross addictions. Often there's also a link to the AA or support community at this point too. Then, once they complete this short-term treatment, which is generally anywhere from 4 to 8 weeks, long-term follow-up begins to help prevent relapse and maintain recovery. So what is the role of the professional in supporting this long-term recovery? First, therapeutic alliance. The substance user must have somebody that they trust and can depend on and come to for a regular basis, an ally as they walk through it. not somebody who confronts them consistently, but somebody who empathizes with them and walks with them through the recovery process. So the therapeutic alliance is the first step. Also, encouraging and creating an individual recovery plan. I'll talk more about recovery plan in a second. Help them develop a relapse prevention plan. Same thing. Meet with family members to provide guidance and refer individuals to outside support groups. So this is an active endeavor on the part of the professional to help support the long-term recovery. And remember, the danger zone is the first 90 days after they complete the short-term treatment. So when it comes to the continued recovery plan, I want you to notice the word consistent in this list. Consistent, consistent, consistent. It is the professional's job to make sure that the client follows up and goes consistently. That is the number one rule. Number one adherence is to consistently go. There's a quote, 80% of success is showing up. They need to show up. And what we see with addiction recovery is that they don't show up. But if we can get them there, they can recover. They have a much better chance of recovery. So consistent, scheduled counseling, and they need psychiatric care to make sure that they're getting the medication they need for psychiatric issues, and if there's continued detox issues. Bringing in the primary care physician, research studies have found, gives an extra layer of accountability and support to the client. So making sure there is consistent scheduled care and that they follow up on it. Consistent planned and scheduled support groups, same thing. Make sure they have them in their calendars scheduled and that they follow up. And then also a family plan, whatever family looks like to them. Family may be one friend, family may be an extended family. That is where the therapeutic alliance needs to be relied on for them to define what their family is. But making sure there is a plan with the family to help with the recovery. Identifying feelings of unworthiness. People who suffer from addiction suffer from unworthiness as they are going through the recovery of addiction. We often call this the hole in the heart, and that means they don't have to sit and wallow in it, but if they can look at this and feel this briefly, but this is just an identifying, but not necessarily wallowing. It depends on the client and their level of self-awareness and openness. Co-occurring diagnosis, treatment, and identification. This is critical because if there's an untreated depression, anxiety, and they want to stay sober and clean, it's not going to happen if the co-occurring diagnosis isn't identified. And then this includes trauma and cross-addiction identification. So that's the role of the counselor, making sure that they are accountable and they follow up and it's done in a supportive way. So the relapse prevention plan. Number one, what are their high-risk situations? Is it stress? Is it when they're around a certain person? Is it going out at night? Is it not getting enough sleep? And it depends on the level of self-awareness of the client to identify these high-risk situations. Some people may have a very difficult time, and it may involve tracing back steps. When did you used to use in the past? When did you overindulge? When were you able to not use? When are the times that it's easy for you to not use? Another thing is coping with the stress, triggers, and conflict, which generally tie into the high-risk situations. What triggers them to want to drink or use? How do they currently cope with stress and conflict? And then dealing with some of the shame. Some of the shame of the things that have occurred, some of the shame of when they have small lapses, different things like that. And there is a difference between a relapse and a lapse. A lapse is a one single use of falling back, and a relapse is an ongoing back into addictive behavior. And the word dealing with shame means bringing it to awareness and labeling it. They don't have to wallow in it, they don't have to sit in it, but they need to identify it and become aware of it. They also need ongoing monitoring of the co-occurring disorders, anxiety, depression, trauma, and cross addiction. And that's very similar to what was just mentioned. And it's helpful for the clinician to help them dig around and look at this, but making sure that they are aware of these issues. That's the number one priority, and that happens only through the therapeutic alliance. So what's the role of the individual? Like I said, 80% of success is showing up. Show up. If they can just show up for meetings and appointments, their recovery will be so much smoother. There's so many reasons that they can give, and it can go into a downward spiral. Had a client the other day who was trying to get off coffee while she was quitting her use. She went and accidentally had a cup of coffee, and so decided not to show up for any of her meetings or sessions that day because she was filled with shame for getting coffee. Instead of just, I had coffee, uh-oh, and then showing up. But that's the springboard. It will be these small things that will lead them to not show up. The individual also needs to be willing to reach out. And reach out looks different for different people. But if they have a number, a support place, anything. And for substance users, this can be one of the most difficult aspects, to actually reach out. How people who have stayed clean define recovery. Being abstinent, being truthful to self. Those are the things I mentioned, of being aware of the shame and unworthiness and the feelings that it gets overwhelming and that they need support, and service. And what is meant by service is thinking outside of self. This can be big, this can be small, this can be actual volunteer work, this can be doing whatever it takes to get outside of self to think of other. Go and pet a puppy. Go take a piece of candy to a young child. Anything that gets them out of themselves and gets them in touch with altruism, even in the briefest of moments. Those are the three things that people say keep them abstinent. So we have a recovery model. It's an approach to mental health disorder or substance dependence. It emphasizes a person's potential. It's seen as a journey instead of a set outcome, and one that can involve hope, a secure base, a sense of self, relationships, empowerment, inclusion, coping skills, and meaning. Recovery sees symptoms as a continuum of the norm rather than an aberration, and rejects sane, insane dichotomy. Essentially, this says no black or white thinking. no black or white thinking. You're not okay or not okay. You are. You just are. And working with them where they are, and every improvement is progress. But it's in all these words of sense of self, supportive. It sounds so idealistic, but it is essentially realizing life is made up of other people and being in touch with these other people and avoiding the wrong, not wrong dichotomy, getting out of the black and white thinking. And so within that definition, and still looking at the role of the client, is identity. So what we found in the research, there's an inverse relationship with higher levels of intoxicants with lower levels of identity development. So essentially, those with lower levels of identity development are more likely to use drugs and alcohol. Those with substance use disorders gradually lose, surrender, or discard aspects of themselves to assume their new social identity when using. So becoming aware of change and the change throughout the process of getting well, and then slow movements of getting back to where they were. And with identity, it is, what do they feel? Who are they? What did they enjoy before they started using? And what you'll find is different levels of self-awareness, which are indicative of a strong identity. More self-awareness in a client, stronger identity. Much easier to overcome relapse, temptations, all of these things. So a focus on this, and this again happens through the therapeutic alliance. Relationships. Those with substance use disorders have a perceived lower social support. And this can have various reasons. They don't trust people. They don't think people are there for them. It can be in fact that they don't have people in their lives. There's several reasons, but for whatever reason, they perceive that they do not have social support. And this is the key to recovery, is knowing that they're not alone. So one of the first steps is getting over the perception of lack of social support and helping them find it. Again, through the therapeutic alliance, you help them find the social support they need. And when it comes to relationships, people with substance use disorders often don't know what a healthy relationship looks like. They don't know what boundaries look like or feel like. They don't know what healthy communication looks like and sounds like. So through this therapeutic alliance and working with them, you can't say, it's not always helpful to say, set your boundaries, because they don't know what that means. It's more helpful to say, here's an example of a boundary you can set with this. You can tell her you can only come between 5 and 7, or you can only come before 10 a.m. And these things, their boundaries, are based on their triggers. So when they set their boundaries, they need to be aware of their triggers. So again, it all comes back to this self-awareness and sense of identity. And the same with communication, to communicate clearly and directly. That doesn't mean they need to spill things to everybody, but to communicate firstly with the therapist, but also communicate their needs. Again, that requires some self-awareness and some identity. So also in counseling therapy, examining previous relationship patterns and style can be used as a teaching point. How did you used to talk to your mother? How did you and your husband talk? right before you would begin to use, what would you talk about? When would you argue? What would you argue about? These are all questions to gain information about their previous relationship patterns, which can let you know their awareness of boundaries and communication. Attunement and attachment. With people with substance use disorders, I always like to assess if they've had a level of attachment with somebody significant ever. Could be mom, could be dad, could be a friend, could be a significant other. Have they ever had a healthy attachment? That attachment we learn about with Ainsworth, secure attachment. Is there an ability to have attunement? And with attunement, that means meeting each other emotionally, mentally, and verbally, being in tune with each other. It's a very similar, synonymous, how about that, with empathy. Have they been empathized with? Have they had somebody be attuned to them? And also with relationships, have they had trauma? Have they been spoken to harshly, overly harsh? I'll get into that a good bit here in just a little bit. And the co-occurring disorders. What impact has that had on their relationships? When they were depressed, it made them, example, not want to go out. It made them not like people, etc., etc. All of these are elements to look at when it comes to relationships and recovery for those with substance use disorders. So what we found is that there's this missing piece with the long-term recovery. And so these people, these 50% that keep relapsing, and they can't maintain long-term care. There's this co-occurring disorder that we're seeing. We're seeing a lot of anxiety, depression, cross-addiction, different things. And the best quote I've heard is, it's actually not on the slide, is that if trauma could accurately be diagnosed, the DSM would shrink down to a teeny tiny pamphlet. And some of these some of these addictions, the anxiety, depression, are in place of dealing with the pain of the trauma. So there's a case that this 50% that keeps relapsing is dealing with some unprocessed trauma. So a missing piece, approximately 70% of those who have a substance use disorder have a history of trauma, and it is resistant to the short-term care. And so as it applies to trauma, ritualized compulsive comfort seeking, what we call addiction, is a normal response to the adversity experienced in childhood, even in adulthood when it's trauma. Just like bleeding is a normal response to being stabbed. Dealing with the pain, people want to buffer it. So some ACEs. Here's what we found in relapsing individuals. 11% have recurrent severe physical abuse, severe emotional abuse, sexual abuse. 25% grew up with an alcoholic or drug user, and all of these are trauma-inducing. They grew up with a family member in prison, grew up with a family member with a mental illness, seeing your mother being treated violently, and growing up with both parents not being present. And all of these, especially if there's 2 or 3 of them, can lead to what we can call complex trauma, which is not something that a client is going to present with and say that they have. It takes some digging around to see it. People with an ACE score of 5 or higher are about 10 times more likely to use illegal drugs, report substance abuse, and inject illegal drugs. Relapse rates for those with trauma are twice as high as those without. Trauma causes neurologic changes in the brain, which increases the likelihood of abusing substances, whether it's alcohol, cigarette, heroin, or cocaine. So this is just food for thought when it comes to ACE scores and trauma. Our findings are disturbing to some because they imply that the basic causes of addiction lie within us and the way we treat each other, not in drug dealers and dangerous chemicals. So billions of dollars spent everywhere except maybe in the treating of the trauma that can be underlying, the not recovering. And I want to pause here and I want to say there are substance users who do not have trauma. There are some that is the case. And these are the ones that probably short-term recovery will take care of the problem. It is the ones where it's an ongoing issue of going back or to becoming cross-addicted or falling into a co-occurring disorder, such as anxiety and depression. These are the ones that are more likely to have the trauma. Those without trauma, again, the short-term treatment may well help it with a recovery plan. So what's the connection between trauma and substance abuse while they can't recover? Self-medication hypothesis. People with PTSD use substances in an attempt to cope with their symptoms. There's also the high risk hypothesis. People who use substances have higher rates of trauma as a result of their substance abuse, usually due to lifestyle choices. 2 notes on this. What we have found is that people who have trauma are more likely to be re-traumatized, and people who do use substances have a higher rate of becoming traumatized with use. But the initial connection of why people become addicted when they have had trauma is that the strongest evidence is for the self-medication, the medicating of the pain with some support for the high risk. Those who specialize in trauma say trauma is stored in the body and the substance use numbs the pain of the unprocessed trauma. It's also part of the reason we'll see the anxiety and the depression because of the unprocessed trauma. And of course, the substances numb it. So there's a there is a difference between PTSD and complex PTSD and also attachment disorder. And what we see is that, like I mentioned earlier, there is a lack of attachment with trauma. Was not a significant person were able to be attuned with or be empathized with that led to the complex PTSD. And PTSD is different in that it is an isolated event that doesn't involve other people necessarily. It is a hurricane, a car wreck, a volcano, house being broken into, a diagnosis, different things like that. It's usually a one-time incident, but for example, a diagnosis can turn into complex trauma if it's ongoing. So there's some different elements there, but the attachment is there with the complex trauma, lack of attachment. So here's our key differences. PTSD is a mental health condition occur in people who have lived through a specific, and that's the key, traumatic event or series of events that have a time limit, or in many cases only happen once. The trauma is not interpersonal in nature. So we do see people having a hard time recover with PTSD alone. We do see that. It looks a little bit different from those with complex PTSD. It is a result of exposure to trauma over long periods, very often starting in childhood, but it can start in adulthood. It can start in adolescence. It can even start in the older ages, but it's interpersonal in nature. It comes from one person to another, and it's traumatizing. And there's not a feeling that it will end. There's a feeling of being trapped. The domains of impairment we see with the complex trauma. And I'll note the ones that we don't see with PTSD. With complex trauma, there was a lack of attachment and impairment there, not necessarily with PTSD. Affect regulation with complex trauma, that's where we see the depression and anxiety. We see that a little bit with PTSD. Behavioral control, we see that with both PTSD and complex trauma. The biology is altered. With trauma, it literally is stored in the body. The book, The Body Keeps Score, is a great one to reference for that. Dissociation, we see that mostly with complex trauma. Cognition, we see that with both complex trauma and PTSD. And self-concept, the way they view themselves is greatly altered with complex trauma. Not so much with PTSD. It is an attachment disorder. Some form of emotional neglect is at its root. Sometimes it has physical abuse, sometimes it doesn't. And we're seeing this more and more in adolescents, where they can get the complex trauma in their relationships there, which can lead to the substance abuse and the difficulty with recovering from that. And if it happens as a child has no one in formative years to model relational skills that lead to intimacy. When healthy relating isn't modeled, survivors don't know how to maintain or find relationships and believe people cannot be depended on or trusted, making finding support in long-term recovery difficulty. I'll pause there. And this relates to, remember how I said that there is a link between perceived social support and substance abuse. So this is exactly where it can come from if it is a trauma that has not been processed. They don't know how to have relationships. And if they did have a healthy relationship, they don't necessarily know it's a healthy relationship. And this is due to, if it happened in the formative years, not knowing how to have that intimacy. So what people with trauma do is they use their fight, flight, freeze, or fawn sympathetic nervous system preference to avoid true intimacy. I don't have a substance user client, a client who uses substances, that I don't try to assess what their preference is, whether it's fight, flight, freeze, or fawn. And we all actually have one that we rely on more than others, even in the healthy sense. So I'll talk about that more in a minute. It's triggering of the sympathetic nervous system. So the impact of trauma. Anytime there's trauma, the body goes into fight or flight mode. Loss of executive function is a protective response because cognition is too slow. When re-traumatized, the brain responds in the same way. The cognitive brain deactivates and the emotional instinctive brain acts as if the traumatic event is happening again and again. And so they get stuck. The person becomes furious, terrified, enraged, ashamed, or frozen. So it happens not only when they are re-traumatized, but at times when they aren't traumatized, because it becomes a default mode over time. Remember, with complex trauma, it's repetitive with no definite end. So it's over and over and over to where they go into fight mode. and flight mode, which is getting out, running away, or freeze mode, which is stop, dissociate. So flashbacks. People who have trauma do have flashbacks, but they are feeling states. And this is where we see the highest rate of relapse with substance users. If we can help them identify their implicit flashbacks, we can help with preventing relapse. So remember looking at high stress situations. One of the top ones are these implicit flashbacks. So they're prolonged regressions to the overwhelming feeling states of trauma experienced as a child, as an adult, whenever it was. And they include shame, alienation, rage, grief, and depression. They trigger unnecessary fight or flight. They are transported back in time, like it was happening in the present, but they don't visualize the event. They are flashed back to the feelings of shame. So labeling it as a flashback, as an implicit flashback, can be difficult to do. In an implicit flashback, people mistakenly believe someone or something is causing these feelings, but they're actually our default mode at this point, the default mode of trauma. Go back. I want to make sure I said everything there. So we'll have more on that in a little bit. So something else we'll see with trauma that you'll see in interfering with the recovery of substance use is dissociation. And left brain dissociation is being obsessive. This can be a triggering cycle that they get into. They can be a high risk, one of those high risk situations you need to label. Obsessiveness, cycling through worries, dwelling on one worry, constantly thinking to distract from underlying pain. What if this happens? What if that happens? Who knows what that'll happen? What if they come here? What if they go there? I don't know. Obsessive thinking. And it's usually on one or two areas that they'll be obsessive about. And this is where we may fall into the dual diagnosis or the co-diagnosis of obsessive compulsive disorder. Another form of left brain dissociation we see with trauma that can lead to relapse is complaining about trivial or mundane things instead of addressing the real pain. That red light took forever. It took forever for me to get here because the traffic was so bad. Why is the traffic so bad? This city is so awful. I mean, I'm sure people, just people who can complain about trivial or, life things. But with addiction recovery, that can send them into a cycle. Trivialization, over-focusing on the trivial, superficial, external concerns to distract from inner concerns. Preoccupation with sports. For example, what am I going to get on this test? What is happening in the news? An over-focus on politics, an over-focus on COVID, but over-focusing on things over and over and over. Intellectualization, an over-reliance to look at feelings. This is when it's all thinking and no feeling. So when I talked about the shame and unworthiness, it's going to be very, very difficult for people who are left brain dissociated to go and even acknowledge that those feelings are in there, much less sit with them. Features of right brain dissociation. And now, as as a side note, these are all ways for you'll see these characteristics as you work closely with people who use substance use disorders. But if you start seeing, lack of recovery, all of these things, in addition to these, start digging around for trauma. Trauma doesn't have to be a big, big thing. It can be having to go to church every Sunday and not speak your thoughts. It could be having to not ever express sadness. That can be traumatizing. Just dig around. So now into right brain dissociation that we see. This is what we classically think of with dissociation. It's the most common type. It's kind of the type where they're just tuned out. And in other words, sometimes we describe them in la la land, numbing, intense feeling, or an inner critic, which I'll talk about, is in a process of distraction and fantasy, daydreaming, fogginess, TV, tiredness, or sleep. So it is just a form of zoning out and not looking at things, getting lost in daydream-like descriptions of salvation fantasies, or in recounting of long, elaborate dreams of emotional content and serious introspection. So we see both forms of dissociation whenever they're having a hard time recovering and there's trauma there. So when we're in danger, our sympathetic nervous system kicks in and it's activated. Like I mentioned, it's flight, fight, freeze, or fawn. And I often give this example. If somebody ran into a room with a gun, what would you do? Would you try to fight them? That's your sympathetic nervous system going into fight mode. Would you run away? Would your first instinct be to run? Run, hide. That's flight. Would you freeze? Would you just stand there and not know what to do? That's freeze. That's your sympathetic nervous system freezing. And fawning is a little more developed. That would be, you would have one of these three, but then you try to talk them out of it. You try to please them out of the gun. Try to work with them. And we need all of these. We need all of these states in our lives. But when one is overused in times of non-emergency is when we get the problems. So here's the positive characteristics that we hopefully see in ourselves. Okay? Fight. When we're assertive, when we're showing boundaries, when we're showing courage, moxie, leadership, that is a healthy expression of our fight response. Flight. A healthy response is to disengage when it's time to let go. Healthy retreat, time for you to rest. Industrious, knowing when to work. Competent, being competent and feeling competent. And perseverance. And I'll pause here before I get to the other two. What we want in our substance using clients is to point out when they are showing these. Wow, that is a great use of your fight response to show those boundaries and then explain in detail. That was a great boundary saying you couldn't go at that time. That was a great boundary saying no. And it's also not to point out that's a great use of your flight response to know when to disengage because it might trigger you to use. That's a great use of a flight response that you know how. You can go and fix that computer, that light, that some know-how. And when they stick to it, perseverance, sticking to the recovery plan, the showing up. And so freeze, a healthy form of freeze. Remember, that's when you just stop if somebody runs in with the gun in the unhealthy state. In the healthy state, they're hyper aware, very mindful. They're ready and they're at peace and they have a sense of presence. And then with fawn, we see a healthy response with that is just love and service, compromise, listening, fairness, peacemaking. And we want to help our substance users for long-term recovery know how to access the healthy responses of these F's. So people without trauma in their history fluctuate between healthy manifestations of these, and they use them flexibly throughout life. And that's our goal with our clients, is to help them know how to use those things as it applies to treatment. Let me go back to it. As it applies to treatment and as it applies to life in general. So some of the distortions. And so whenever relationships are hard for people who have used substances, people in the field of trauma tie that to the lack of attachment and the trauma that has occurred. And as a result, and depending on which of their F responses they are, this is how they react in relationships. The fight type. They try to control other people to connect. They will rage to be safe. The flight type. They will perfect to connect and perfect to be safe. Where I see the flight in substance abuse is the black and white thinking. Well, I wasn't perfect. I didn't do it all right all day. So this perfectionistic standard will kick in. And if they didn't do it perfect, it sends them to want to relapse. So keeping that in check goes back to the black and white thinking I was talking about. So the freeze type, they think to themselves, there's just no way I'll connect. They hide to be safe. They don't even try. There's not really an interest in trying to connect with other people. And the fawn type, when it comes to social support and trying to connect, they merge. This is where we see what we would consider codependency. They merge to connect, or they grovel to be safe. So look for these relationship patterns. So I was talking earlier, relationships are key for long-term recovery, and picking up on what their past patterns are. And you pick up on these past patterns by asking, how did you react when boom? How did you react when y'all argued? How did you react when things were happy? How did you react when you thought he was bothered? Just gathering information to see what instinct they may tie to. Where we might misdiagnose trauma as opposed to just missing the mark based on their F type, because people with a very strong F type, over-reliance on an F type into adulthood could lead an individual to look like these different diagnoses. So they have a strong fight type. They can look narcissistic and seem antisocial. So we get this a lot in the substance use field. They're narcissistic. They're narcissistic. Give it a chance to step back and examine if it's someone stuck in the fight zone, because they look very narcissistic and antisocial. The way I differentiate is people with trauma stuck in the F type, the fight type, is they have guilt and self-awareness. There is some level of awareness of things that they've done wrong. Awareness that their substances hurt other people. That, but they may still have a lot of the characteristics of narcissistic. And they also are able to say, you can say, is there something that has made you feel guilty? And they can label things that elicited appropriate guilt. You're more likely dealing with somebody stuck in the fight type of trauma as opposed to a true narcissist. or antisocial. So just keep that in your back pocket. With flight, what it looks like is obsessive compulsive disorder. Remember, even just in the healthy type, it's really just working hard and doing things. But when flight is overused, it becomes obsessive compulsive. I have to do this, I have to do that, over and over and over and over, and it can become anxiety. And then we have the addictions, and it can look like ADHD, and it can look like bipolar. So keeping in mind that it may be somebody stuck in the flight zone, and where I try to differentiate here is, are there times when it comes down? Is there a level of self-awareness with it? And then there's the freeze type. It could be, we may label them with dissociation, depression, dysthymia, schizotypal, Asperger's, and avoidant. People stuck in the freeze type can show those symptoms, and it's not to say that they don't meet the criteria for dissociation in the DSM-4, but it may be stemming from trauma stuck in the freeze type, freeze response. And then we have the fawn type. And what we see there is dependent personality, depression, lack of sense of identity. And this is where we might label somebody borderline too. So stepping back and looking, is this over-pleasing a learned response from childhood to avoid the trauma, to keep safe? Or is this a diagnosis in and of itself? And where it matters is how you treat it. Because if it's more trauma-based, the treatment looks different than if it is true narcissism, borderline, or Asperger's. So if you have somebody using substances who's not recovering well, or even anybody who's, they have this inner critic. People who have used substances, generally speaking, once they start working through it, it's a key defining characteristic between PTSD and complex PTSD. And this is, let me give you an example first. I'm not good enough. I can't do this. I'm not smart enough. I'm stupid. I'm fat. I'm not worthy. I don't deserve to be here. On and on. These are examples of an inner critic in a client's mind. And when there's trauma, it's the disgust, rage, scorn, or neglect the parents or the traumatizer felt towards the child, the substance abuser, and they take it on as their own voice. Because this voice was fed to them over and over, they've now turned it to where it is their own voice saying these things to themselves. This disgust is what causes the shame. One of the causes of the shame that I spoke about earlier that we see in addiction. Look for it in all cases of depression, anxiety, and substance abuse. Process addiction too. It is insidious, and some people live by their inner critic. And detaching and removing themselves from their inner critic is a process. The first step is identifying it as such. I've had clients get help with naming it. It's my mother. It's the green man. It's the inner critic, sometimes they'll call it. Just a different, it's the roar, whatever the case, but that helps to externalize it from them. But our job is to identify that an inner critic has a hold on them. And that is going to be a very large interfering factor with long-term recovery from substance abuse. If their inner critic is yelling in their ear that they're a loser. So breaking free of that is a critical step. How it develops, said a little before, There's a little more. When they fail to receive validation or approval, they fail to form the attachment, which we've talked about. They become anxious and fearful. They adapt by developing hypervigilance and or perfectionism, or it could be the fight or the flight. They could run away, or they could go fight in the sense of arguing with siblings, arguing at school. The perfectionistic, seeking, hypervigilant child can only think of how they're not good enough based on the words of affection. The child's sense of self, aka their identity that we talked about earlier, their identity has no room to develop and becomes that of the message their parents sent or did not send, and the inner critic develops. So this is very, very intertwined with not letting a substance user or a client develop an identity. Their identity becomes those words that have been fed to them. So some examples of some things I've seen. A lot of times when people are growing up, they're treated harshly or criticized when they spill things. And so anytime they make a very small mistake, they will label themselves. So a client in 3 years of sobriety, it was in a stressful time in her life. And literally, and there was a buildup of a few other things. It was a spilled milk. It was a spilled milk. So she came in, her parents called her a klutz. But so she was a klutz, she spilled, she was on a date, first date. And so she could not leave that down. And so from that isolated incident led her into relapsing, because she could not get over the glass of spilled milk, triggered her into an internal critic, an implicit flashback of the state that she was before when she had been holding up so well. And I don't mean a lapse, I mean a full relapse. Gift giving. The fawn type had a client who in recovery would like to give gifts to people, and gave a gift to a boss, and the boss didn't enjoy the gift, and so from then on she was stupid, led her into a relapse, an implicit flashback that led her into a relapse with at least a year of sobriety. I have a client who will misspeak. She used the wrong words, it happens. But his MO with it would be, I'm a screw up, I'm a screw up, I'm a screw up, I'm a screw up. And anytime this would happen, it would send him into a lapse, a day or two, and he's further a screw up. And so the cycle continues. So the work with each of these is identifying those words that were spoken to them as their internal critic and the voice of somebody else. And putting it in perspective, remember, this is stored in the body. It's a default. It's not something they think about, and they don't realize it's going on until you point it out. Most people with a strong internal critic, really into their implicit flashbacks, don't realize how much time it consumes of them. So it takes our therapeutic alliance with them to listen to what they're saying and the repeated words they're saying to themselves with the mistakes. Remember the recovery model, black or white thinking, no black or white thinking, as much as we can. It's a notion of good enough, and I'll get to that in a minute with recovery. So there's a sister to the inner critic, there's the outer critic. So where the inner critic views the self as flawed and unworthy, the outer critic views the rest of the world, everything else is flawed and imperfect. It's too hot in here. Doesn't smell good. Food's too hot. I don't like what they're eating. I don't like where they're meeting. I see this a lot with just PTSD. Less with complex trauma, you'll see it also, but you'll see it with PTSD, and you will see it with some clients when you're trying to help them find an addiction group. No, there's too many smokers there. That no, that leader wasn't nice, or that person wasn't friendly, or all those people work at a certain, there's all these reasons. This is what we call a strong outer critic that interferes with any relationship building. So it uses the same programming of perfectionism and endangerment against others that the inner critic uses against self. And it's a consequence of untrustworthy parents generalized to all others. And this, it avoids emotional investment in relationships. This is the ultimate relationship intimacy killer, because everybody will be flawed. Everybody will be flawed. There will always be a reason why they can't be with this group or that group. And so, taking into account, this outer critic, how do you tear it apart? I say, honestly, I think the outer critic is harder to work with, harder to work through than the inner critic, because once you start teasing it apart, well, it's wrong. It's, they're going to find a reason. It's more difficult to work with. And the steps I take with it are, is there anything that's good enough? And I don't mean the gratitude, what are you thankful for? What do you see that's good? Not that route, because that was actually sometimes traumatizing for people. Their parents would say to them, just be thankful, just be thankful. So that can be a triggering emotion too. But having them to find a place that's good enough, okay enough, acceptable, whatever words will work for them, that can keep them out of that strong outer critic zone. So the outer critic alienates others, and it prevents them from seeking support in long-term recovery. And eventually, and it can turn into the outer critic starts poking at the therapist, and so it can be difficult to work with and through, but it can be worked through. So we see passive aggressiveness in the outer critic too. And why do we see that? So abuse or neglect makes people angry, but the power that these people have, and I'm purposely not using the word parents here, even though it says parents, but this can also happen with a significant other or a friend. That anger cannot be expressed. So this unexpressed anger can become a vast reservoir of resentment that's projected onto others through passive aggressiveness. The outer critic thrives on judgmental condemnation and hurtful backhanded behavior. So it all goes back to this notion of being hurt and let down and not having power, but they can't speak it. They can't speak it. So their identity becomes one of hurt and rejection. So how do we merge this trauma-informed therapy? Because remember, those that relapse probably have about a 75% chance of having trauma. So how do we merge this trauma-informed treatment for this long-term recovery that that these clients need, that these substance users use? So what does it look like? It's a little bit of a paradigm shift away from traditional substance use, and it just adds in, it adds in some trauma-informed care. And so what trauma-informed care, remember, this trauma is a learned set of responses, results from an inability to complete some developmental tasks. This is environmentally not genetically caused. And it is different from other diagnoses. Like I mentioned, it is different from the narcissism or true autism or Asperger's or ADHD. Okay. And remember, it's environmentally imposed. And we know some addictions there's a genetic component there. So if you put the trauma on top of it, when there's already a family history of addiction, you have the environment of it, but also the genetics. It's really difficult if you don't take a look at this. So our treatment is influenced by the mechanisms they've been using to cope. So what are their co-occurring disorders? And I'm saying that a little bit with, so we have the addiction. Do they sleep too much? Do they have an eating disorder? Do they have depression? Do they have anxiety? How are they coping? How are they coping? So they were coping with an addiction and substance use, but they don't have that anymore. But they still have the pain of the trauma. So what are they doing? Are they now focused on their body image? Are they eating too much? Are they depressed? Are they anxious? And then what is their F type? And what is their inner and outer critic stance? Most people are either have a stronger inner critic or a stronger outer critic. So identifying that can help you know which route to go with treatment too. Substance use disorder treatment can be re-traumatizing for some people. Okay, so our traditional substance use treatment, here are some things to just keep a lookout for. Our number one goal with trauma is not to re-traumatize, because they're easily re-traumatized. Remember that once they have a trauma, it builds. Okay, and by the time we get them, there's usually 2 or 3 traumas. So concepts in AA, NA, this concept of powerlessness can be re-traumatizing, because remember, in trauma, they were often left powerlessness. That somebody else is the authority, that the counselor is the authority. I tie it back to going with motivational interviewing here. The client's the authority on their story. Let them run it as much as they can, but you facilitate it. Remember, therapeutic relationship, first thing. That is the first thing. Be careful with our confrontation tactics. That can send people into flashbacks. Shaming practices can be re-traumatizing if it happens in a meeting. An over focus on character defects can be re-traumatizing. The notion addicts can't be trusted to tell the truth. Discharges for non-compliance. Punishing aggression as opposed to trying to understand what is causing aggression. Not giving choices for recovery. And then withholding medication-assisted treatment can be re-traumatizing. So how the 12 steps work with trauma-informed. They can be very valuable and evidence-based, and we all know they need that social support. The relationship-based program of recovery can be both healing and at times it can be triggering. So where it gets tough is realizing when they don't want to go to a meeting, is it triggering them to be re-traumatized, or is it their outer critic? So trying to tease those apart can be one of the struggles that we have in moving them forward. So just know that. And unwillingness to participate is common and expected of someone who has experienced trauma in relationships. People who have trauma don't trust people, generally speaking, and relationships are dangerous. But what is damaged in relationship can only be healed in relationships. So that is our dilemma, that is our challenge with people who have this, have had trauma, and are battling this long-term recovery, is finding safety in the programs and in the meetings and in the support. And it's baby stepping them into it very slowly until they can find a safe spot. So implications for treatment. So we can't just treat the substance as a primary and singular disorder. We have to examine how we do treatment today and be willing to change our practices so that we're responsive to trauma individuals. Trauma-informed treatment and trauma-specific interventions need to be an integral part of substance use disorder treatment. People who do not have a significant trauma will respond positively to a trauma-informed approach. So even if we can't put our finger on a specific trauma, all these principles are really helpful to keep in mind, because sometimes the support, that it just doesn't feel safe, and they need to feel safe, and we need to make sure they're not traumatized. So a little bit of rethink. For many individuals, substance use behaviors, remember, they're an adaptation to pain. Whether it be the trauma, the anxiety, the depression, it's an adaptation to pain. And the disease model is extremely useful. But the risk is that we seek to intervene through the brain only, and we ignore the body and the body-mind connection. And in saying that, that is the sympathetic nervous system. That is our fight, flight, freeze, and fawn responses. We must pay attention to their predisposition, their disposition, of how often their sympathetic nervous system is being triggered into fight, flight, freeze, and fawn mode. And that requires a little bit of bottom-up treatment of looking at where do they go when the stress is there. Recovery is stressful. Recovery can be hard. And so what do? Do they want to freeze and do nothing and lay in bed? Do they want to run away from it? Do they want to please everybody around them? What do they want to do? What's going on below the brain? You know, what's going on in the heart? What's going on in the nervous system? The focal points: cognition, emotion, and body. What they think about, what they feel, and I talked about that a good bit, bringing it to awareness, the shame, the unworthiness, but also what makes them happy. That's part of the identity development. What does a good relationship feel like? That's the emotion. Staying in touch with these things. And then the body, where do you feel that? Is it a headache? Is it a stomach ache? Where does it affect you? People with an addiction, with long-term recovery, they will not say to you, I have complex PTSD. It won't happen. It's not going to happen. It is up to us to dig around to see if there's trauma there. And 50% of the traumas I've seen don't look like trauma initially, but they were traumatic to them at the time. And it takes some digging to see what they have stored in there until some fight response is restored. So if with our freeze types, with our flight types, and our fawn types, and I'm going to say mostly the freeze types and fawn types, they've got to have some fight response restored. For some of them, they've been so beat down They're so frozen and pleasing that there's not that fight. Remember those healthy components of fight? We got to get some of that restored in them before this CBT or psychodynamic or these other techniques that we're trying to use will work. There must be some fight response restored. I can't hit that hard enough. Some people have had the fight just taken right out of them. So it doesn't do any good to CBT them. Treatment at a cognitive level, awareness. And I talked about this at the beginning of developing awareness of their triggers, of their feelings, and goal. They got to separate from their inner critic as much as they can. Eventually, a little bit of insight into the abuse neglect pattern. Some people can't talk about it. Some people can't view it as trauma. Some people can never get there. But if you can get just a little bit of insight in for them to see when you were treated this way, it affected the way you view relationships. Helping them to see that they didn't deserve to be treated that way. The best way for that is the modeling through the therapeutic relationship too. Treating them with the respect that they deserve. Clients are very often helped by learning about the F response notion. The fight, flight, freeze, or fawn, very often. And it's a safe spot too for them to talk about. And it also lets them see this is how you survive. This is how you make it. This is how you survive through the trauma. But you're safe now. And awareness, developing the awareness of when it kicks in for them is very important. Help them see connections to how they were treated with how they now respond to different stresses. Again, awareness. Not necessarily always doing anything with it, but if they can look at it. And so our cognitive healing involves finding more acceptable ways of thinking about and talking to self, recognizing the source of the poor self-perception, and then place the blame on the actual wrongdoers. And so cognitive work can be very helpful in the process of disidentifying from the self-hating critic. So the cognitive work is what I mentioned earlier. Learning when it's there. Is it there just at work? Is it there at home? Is it there when you're fixing to use? Is it there after you use? Is it there after you spend too much? After you eat too much? When does that critic come? And helping them see when it's there. So the cognitive tools, CBT, they're important, but people who have complex trauma have discovered it not by itself. It's almost putting a Band-Aid, just a little bitty Band-Aid on a wound. So it'll get them through a day or two. But they can't CBT themselves well. They certainly have their place, but they're not a long-term recovery treatment. Cognitive work helps an individual disidentify with the critic. Again, some of them are so entrenched with their critic, it's a part of them all the time. They think they are their critic. So helping them to differentiate between what is a voice and what is what they see and think. So emotional healing, two key emotions that we need to see is the first one is grieving. One strategy for reconnecting with the emotional self is through grieving. A person can be led through a process of grieving what they lost due to trauma or neglect. It's part of a death oneself, which may allow for the rebirth of some emotional intelligence. Grieving quiets both the outer and inner critic and may stop flashbacks in the moment. So this is one of the only tools, one of the few, how about that? One of the few tools I found for breaking out of an outer critic stance is sadness, pain. They don't necessarily have to cry, but if they cry, but grieving can get people into the here and now, the feeling. And people think, oh, I just need to grieve this and get over it. For the most part, grieving doesn't end. And we don't need to tell them that if they're the type that can get overwhelmed with that it's going to be there for years and years and years. But grieving is a process. It doesn't happen in a session and they're better. But it's a process and it comes and goes. But it breaks them out of the outer and inner critic and makes them fully present in their body at that moment. So that's one of the big things is some grieving, sadness, feelings, in touch with that over what the addiction's done, what any sort of trauma has done. If you can get them to that spot, a lot of healing and processing can occur. Part of grieving is anger. So if we can also get our non-fight types, particularly the freeze and fawn, to get in touch with a little bit of anger. It can be anger at trauma. It can be anger of their use. It can be anger that alcohol was ever created. These are all things I've seen. Anger over the door being left open so the addict could get in. Anger over the car being stolen, which led to the relapse of 6 years. Anger. Get in touch with the anger and feel it. They don't have to feel it. They don't have to, for long, they don't have to mull in it. But generally, if people accurately have their anger on target, it dissipates. Anger is not an emotion we should push down. There's a little exception with the fight type. If it's disproportionate and mistargeted, that's where we keep a lookout. And here's a caution. For some people with trauma, anger can send them into a flashback if they were punished for expressing strong emotions in childhood. And we can see that not only with anger, we can see that with grief, we can see that with tears, we can see that with all of it. If a child or a person was punished for a particular emotion, feeling that emotion or expressing it as an adult can send them into a flashback. And these flashbacks are relapse producing. They will make them more likely to relapse to their use. So verbal ventilation, allow the speaking out of painful feelings and allowing feelings to come out verbally can lead a person out of a flashback by giving voice to emotions of the hurt person, allowing the adult, the child has become to feel the pain. Acknowledged in that way, pain can be mourned, and verbal ventilation quiets both the inner critic and it can quiet the outer critic too. So the inner critic resists grieving at times. These are quotes. Quit crying or I'll give you something to cry about. Lots of parents spoke that. So even spouses in trauma cases will hear that. So Grieving may lead into a flashback, recalling words spoken by traumatizers. Some trauma survivors learn to quiet the inner critic before they can begin the grieving process. So for some people, they have to be able to externalize that inner critic. You're not good enough, quit crying, babies cry. These are all inner critic words I've heard. If they can externalize that, then maybe they can move forward with some processing of it. So loneliness, such a trigger for relapse, and the shame that binds an individual to loneliness, it's got to be healed. This is where group work can be so helpful for the relational shame. There is more vulnerability in a group work compared to one-on-one sessions, but keeping in mind the items I already spoke about, that they can be triggering, and finding that safe spot can be very difficult. And a lot of times it requires some rewiring of the brain, that it's good enough, that it's okay enough, and less of a focus on well, what's good about, what did you get out of it? The gratitude trap is what we call it. But getting them out of the loneliness stance, very strong in helping recover and stay sober. Like I said, trauma stored in the body. It's pre-verbal. The traumatized body re-experiences terror, rage, and helplessness, but it's hard for them to articulate these feelings. So they have a lot of cover stories to explain their symptoms and behaviors. And the stories will rarely capture the inner truth. The experience of trauma shows up in their responses with the fight, flight, freeze, submit, and attach. So if we stay on the lookout for these and looking for the stories of the medical issues can also be a sign of trauma that has occurred that is making it hard to recover fully, especially with the opioid addictions. We'll see that a lot. Like I said multiple times, good enough, good enough. What is good enough for them? Term used by scholars and therapists to describe discarding of the perfectionistic, unrealistic attitudes towards relationships and life in general. And being perfect, adopts reasonable expectations of good-heartedness and consistency in the support, protection, forgiveness, and comfort one receives from either a parent or anybody. And it allows for the ability for the attachment I talked about at the beginning, and the attunement, and the joining of groups for the social support. So again, avoiding the gratitude trap, asking people with trauma and having difficulty recovering to find things to be thankful for can trigger them, be very triggering. Many were told just be thankful, or you're so entitled, or nothing's ever good enough for you. You're spoiled. These are all very, very, very common words. And a traumatized individual and people who use substance abuse, so staying off the gratitude trap for a little bit, and you can test it out and see how it does. For some people it resonates, for some people it doesn't. Again, another option is to present the notion of finding things that are good enough and see if the person can generate things versus finding a certain number of things to be grateful for each day. Generate things that are good enough, good enough. So spirituality, it's a lot of potential, because people with trauma, they often feel unwelcome and lack that, and it makes sense that a transcendent, sense of belonging is attractive. So this idea of something bigger, something greater, having a sense of place can be very healing, both for people with the trauma, um, and those struggling with the addiction. And so working with the body. So movement can be a primary adjunct therapy and should incorporate sensory motor approaches. When the body settles, the sympathetic nervous system, it makes it easier to work through the emotional and the cognitive modalities. See, yoga, walking, movement, breath, all these different things will encourage the awareness that have been cut off just, with in the long-term recovery, with just the addicts with the trauma, without it. So angry and grieving the losses from the trauma begin with awareness of the patterns that were ingrained. With practice, the inner critic can be silenced and recovery made a way of life for those affected with complex trauma. This is a step towards avoiding the need to numb the pain of unprocessed trauma with substances, helping with the relapse. And so what do you think? So that is actually the end of my presentation. So I can take, what we can do is we could take, do we want to take a 5-minute break or do we want to go just to questions, Rebecca? I'm good either way.
Go ahead and head into questions. I see a couple in the chat. If you can open your chat and you can see them, some of them are what is damaging in a relationship can only be healed in relationships. Is there any stats on veterans with severe traumas?
Okay, good. Okay. Let's see. So the question I hear is the stats with vets in severe trauma. Is that right?
Yes, it was. Is there any stats on veterans with severe trauma?
Oh, I'm sure there are. I don't know off the top of my head, but what we see in veterans is we see more of the PTSD versus the complex trauma. So although there's isolation and things like that, there's going to be a little less of the inner critic that has developed, but the recovery rate is equal to those that have the complex trauma. The relapse rate is harder to overcome with them. I think that's on target there because they're so trauma inducing and they're probably very isolated too. So you can assess it by how isolated they are, for sure. But off the top of my head, I don't have stats. Yeah. Okay.
I see another question that is how does trauma affect people of color, and is it different than the rest of the population?
Well, that's a great question. I'm sure that there is a cultural component to how they were able to express themselves in times of trauma and how they can express themselves to other people. So I would say there is going to be a different, and I would ask the clients on that, anything that's multicultural or it's a client who's culturally different from myself, I would ask them to educate me and say, does this resonate with you? Did you see this with your life? But it is going to look different with them, and it may be even more normalized there, and it may be harder. What we may see as trauma may be perfectly normal for a particular culture. So keeping that in mind too, of what would be deemed as traumatic there might be different from how other cultures view it. Let me see. Are there any others you see there, Rebecca?
Yes, I do. Someone asked, can you explain the fawn model a little more?
Yes. The fawn model is people pleasing and a sense of self-sacrifice to get in good graces with people and to get along with people. You'll see this with people who in relationships lose their sense of self and their identity and will continue to please. An example client would be one who was continually abused because of not doing everything and doing it all perfectly, but would still fall into default that she was the issue. Even though she was doing all that she could, her happiness, her world, her life depended on pleasing those around her to the point of losing her identity. You can see it in males and you can see it in females. And you'll see it in some cases of trauma and abuse and in recovery. You'll see some relationship jumping there with the fawn type. And again, if you look at the diagnosis for codependency, you'll see a lot of similarities with people in the fawn type and codependency. And the treatment for that is to focus on identity development and what they need and what they want.
So then we have another question of what is meant by cover stories? Can you explain that?
Think back of when I said that, because I know I did say that. Just a second. Okay, yeah. This was with people will sometimes consciously, sometimes unconsciously go into long, elaborate stories for why something is wrong without touching on the root issue. Well, I had this surgery, I had this leg broken, I had this happen, as opposed to addressing a real issue, which was the trauma that occurred or the lack of attachment. So they could be cover stories they tell themselves. So we'll just call this denial. How about that? So denial to themselves and denial to other people of things that happen and have happened, of avoiding looking at and dealing with the pain of the addiction and the pain of whatever other issue. But cover stories are things that keep them from looking within. I hope that answers it.
And then we have another question of, can you explain more about verbal ventilation and why it's encouraged in treatment?
That's good. Verbal ventilation is expressing and getting out the feelings. With our fight types, it's not usually needed. It is with our freeze types and our fawn types. If we can get them to express the sadness, the anger, it can help them look at it as opposed to being stored within. When things are not brought out onto the table, they cannot be dealt with. So with verbal ventilation, it allows us as a clinician to hear what's going on and to work with it. And it can help move them forward in the feeling and the looking at it. Because a lot of times it's just these feelings are stuck down in there. But if we can get them to ventilate, express, and talk, it can move them forward as opposed to becoming stuck.
And I don't see any other questions coming in. Does anybody else have any other questions they would like to ask at this time? All right, I do not see any other questions coming in, so we will go ahead and conclude today's webinar, but I have a couple of items of business before we begin. First of all, I want to thank Dr. Byars so much for putting on this webinar, putting all of this information into it. We've included her contact information on the screen right now for you. If you have any further questions or anything else you would like to ask her. So thank you so much for all this information that you have shared with us today, Dr. Byars.
Yes, thank you so much. Thank you all for attending. Appreciate it.
And just a few more items of business before we conclude today's webinar. Please see the chat panel for a link to today's evaluation. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on FADA's website. If you want to receive CE credits or statement of credit for this event, you must take the evaluation. You will be prompted to register or sign in to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix number when you registered for this webinar. After you register or sign in, you will be directed onward to the evaluation. You must use the same email address you used when you registered for today's webinar as what you have listed within your FADA profile, as this is the only way for us to connect your attendance and your profile. You will get a second opportunity to complete the evaluation through a follow-up email later today. The evaluation will close midnight Tuesday, November 29th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 business days after the evaluation closes. Thank you for participating in today's webinar. We'd also like to recognize and especially thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Thank you all and have a great rest of your day. And please remember the evaluation will close Tuesday, November 29th. Thank you all. Have a nice day. Thank you, Dr. Byars.
Thank you.